providers to have different sets of rules that apply to Medicare and non-Medicare. So the new regulations are clear in that they apply to Medicare and beyond the Medicare program. The three exceptions and safe harbors that I'm going to talk about to begin with really have a correlation between the amount of financial risk you're assuming and the complexity of the exceptions. So basically, the more financial risk a provider assumes, the simpler the exceptions and the safe harbors will be to meet. The smaller the amount of financial risk that a provider assumes, the more complex the exceptions will be. And we're going to talk about the exceptions and safe harbors at the same time. And the reason for that is because there's a lot of overlap between these rules. So this slide here basically sets out what I would call the architecture for the exceptions and safe harbors. I won't go through all of these terms, but essentially what this chart outlines is a series of definitions that providers need to be satisfying if they're going to be qualifying for one of the exceptions or safe harbors. So essentially CMS for Stark and OIG for anti-kickback are defining what they mean by value-based activities and what they mean that providers have to do to participate in these value-based arrangements. So for example, any program that's acting in pursuit of value-based reimbursement needs to be in pursuit of one of these four purposes that you see where it's described as value-based purposes. This is what CMS and OIG define to be the permissible goals under the exceptions and under the safe harbors. So each of these terms, and as far as value-based activities, value-based arrangements, the purpose of the value-based arrangement, treating a target patient population under the program, all of these definitions have to be satisfied for providers to qualify for an exception or safe harbor. You also have to think about who can participate in these arrangements because CMS and OIG are basically saying that all providers are not treated equally. So there are a series of provider categories that are specifically excluded from being able to participate in these exceptions and safe harbors. And really what CMS and OIG are focused on here are those providers who tend to get most of their business through referrals. So laboratories, durable medical equipment companies, and then pharmacies and are currently proposed to be excluded from participating in the value-based programs. This is an area where comment is probably warranted because one of the things CMS is saying is that if you're a health system and within your family of entities you have a lab or you have a durable medical company, they're considering excluding you altogether from being able to participate under one of the exceptions and safe harbors, which doesn't seem like a great result, particularly if lab or pharmacy or DME is a very small component of a much broader organization. Other things they're interested in getting comments about in terms of who can participate in these arrangements has to do with healthcare technology companies. So the government agencies are aware that there are a lot of entrepreneurs, a lot of tech companies that are developing software, that are developing applications that can be very helpful in pursuing value-based objectives in terms of informing patients about the status of their care, helping providers understand whether patients are performing in accordance with treatment plans. And the government agencies are basically saying, we don't have the expertise to understand how these tech companies should be analyzed under the anti-kickback statute and the Stark law. So please tell us how we should analyze those organizations. The full financial risk exception and safe harbor, as I mentioned, really offers the broadest scope of protection. This slide here outlines a few of the common elements between Stark and between anti-kickback statute. And basically what they're saying here is if you're participating in this as a healthcare provider, you need to be at full financial risk for a target patient population for a specific period of time. So what does that mean? Well, the examples they give would include things like, the value-based enterprise, so that's basically the collection of parties participating in one of these arrangements, agreeing to assume prospective capitated payment for all services paid under Part A and Part B of Medicare for a defined patient population for a period of time. So you're basically saying, we will take care of all of the patient needs for this group of people for this period of time, and we're assuming the financial risk for doing so. And if you can meet that standard, That's how you show full financial risk for purposes of this exception. The agencies try to make clear that what they don't mean by full financial risk is if you're taking risk for a limited subset of services. So, for instance, if you have a hospital that's participating in a bundled payment program for knee replacements, for example, that would not be full financial risk, because in that situation, the hospital is only assuming risk for a defined type of service. The regulations go through and make a number of other requirements that organizations have to meet. So, for instance, you can't induce providers to reduce medically necessary services. That's a requirement under the federal civil monetary penalties law that's now being added to the Stark law and to the anti-kickback statute. Not surprisingly, you can't set one of these value-based payment programs up in a way that induces referrals for patients for services outside of the value-based program. So in my example about assuming prospective payment for all services under Part A or Part B and Part B of Medicare, that arrangement could not require the participants to refer other services to the parties participating as a condition of qualifying for participation in the program. Anti-kickback have a few differences under the full financial risk exception in safe harbor. They're outlined on this slide here. Interestingly, the Stark law doesn't even require a written agreement to participate in this full financial risk exception, but you do need to keep maintaining records of the arrangement for a 6-year period and producing those records to the regulators on request. Anti-kickback statute is a little bit more rigorous. A written agreement's required, term of 1 year. You need a signed agreement in place in advance of the arrangement to participate under the full financial risk exception in safe harbor. The second exception in safe harbor is kind of the middle ground between assuming financial risk that's at the full level and then assuming no financial risk. And CMS and OIG describe it a little bit differently. It's referred to as meaningful or substantial downside financial risk, depending on what law you're talking about. And basically what this is about is trying to draw a compromise for providers who are willing to assume some financial risk for treating a patient population, but not assume all of the costs of care of treating that patient population. The next slide here will give you a chart that outlines exactly what OIG means by substantial downside financial risk and what Stark means by meaningful downside financial risk. And you'll see that the requirements are a little bit different. I won't go through these, but if you're interested, you can read the guidance here on this slide. Basically, anti-kickback is saying the organization itself, so the value-based enterprise itself, which means all of the parties participating in the arrangement, need to agree together to assume substantial downside financial risk. And there's 4 different ways you can do that. They're outlined in the upper left box on this slide here. And then the participants, each of the individual participants in the arrangement needs to agree to assume a portion of that financial risk. And there are 3 different ways that the parties can meet that obligation in the lower left box on this slide here. Stark is a little bit simpler. In Stark, the Stark exception only requires the physicians at issue to assume meaningful downside risk. And there are 2 ways you can do that. They're outlined in the box on the lower right corner of this slide. And as far as explaining to folks exactly what this means, CMS and OIG try to give examples. They say, for instance, if you're a hospital that simply participates in a Medicare prospective payment system, which most hospitals do, that's not what they mean by financial risk, right? Because, all hospitals have to do that. A lot of hospitals will probably say, well, we do assume financial risk because we get paid based on this formula regardless of what happens. But CMS says, no, it's requiring something extra than that, and that's really what the detail on this slide here is intended to drill down and indicate. Stark and anti-kickback have a few differences in terms of this exception, and they're outlined on the slide here. Interestingly, this exception in safe harbor and the full financial harbor protect both monetary and non-monetary remuneration. So that means the parties can fund, hiring staff, or they can donate equipment, they can donate, supplies, office space. Really no restrictions on the scope of what's protected under the exception. But the OIG starts to get a little bit more specific than Stark with the meaningful downside financial risk safe harbor. So what they're talking about is you need to be able to demonstrate under the anti-kickback statute that the remuneration you're getting, so if it's money or people or equipment or space, technology, that's used primarily to engage in value-based activities that are directly connected to the purposes you're trying to accomplish. And the guidance goes through a couple different ways as far as how folks are supposed to make that clear to the government agency.
Question here.
Yes.
And we work primarily with medical device companies. But
okay.
The bullet point that says no marketing or patient recruitment activities, of course, we do a lot of that in the industry, and we can find safe harbor ways to do it if the healthcare provider has some skin in the game, right? Are you saying if it's in conjunction to a value-based activity, they don't want you to also be doing marketing or patient recruitment activities?
Good question. So first of all, device drug companies, people who make things currently will not be eligible to participate under these.
Okay.
Right. So that would be, and a lot of folks will disagree with that interpretation at CMS and at OIG. Yep. So you'll want to think about, telling them why, the good reasons why you might want to participate. Second, what they mean by marketing is you can still do marketing, but you need to do that under a different exception or safe harbor. You can't squeeze that into this range.
Got it.
Is what they're talking about.
Thank you.
Yep, no problem. The third, yes. Yep.
So my reading was that pharmaceutical industry explicitly, pharmacy, DME, et cetera, explicitly out of this agreement.
Right.
But it's yet to be determined and feedback on the medical device industry as to whether or not they should or should not be included. But you just kind of lump those together. But did I misread that, or?
I don't think it's totally clear what CMS and OIG are saying because, so for instance, they kind of punt on that a little bit. There's a list of organizations that are very clearly carved out, and then there are a few others that I would, squeeze under the sort of manufacturer category where they're basically saying we don't have enough guidance right now to say one way or another whether an organization can participate or not. So you need to give us that kind of feedback to qualify. Yes.
Could you qualify the scope of no marketing or patient recruitment activity?
Sure. What I mean by that?
Yes, the scope of that. So, for example, is a brochure or something on your website?
Yeah, no, it's a great question. So they draw a distinction between that kind of activity that's basically trying to let people know about the value-based program. So here's why you as a patient should come participate at, clinic XYZ. We do a great job because we have hospitals and physicians and acute care providers working together. That's fine. But what they don't want you to do is to try to give people financial incentives to get other services from the same participants, participating in the arrangement. So you take my first example, it's okay, but then if you extend the communication to the patient and say, oh, and by the way, we have an amazing imaging center and we have a great laboratory program and we do all kinds of transplant work, and that doesn't have anything to do with the value-based programs. That's what they don't want to be incentivized under these exceptions. So basically what it means is you can't have the remuneration paid to fund those additional marketing activities. Does that make sense?
Yes, thank you.
Okay. All right. Good question. Thank you. So the third exception here is kind of is sort of the catch-all exception where you don't have any financial risk assumed by the providers participating in the arrangement. And this is basically saying, we understand people want to participate in these programs, but maybe they don't have enough experience to be willing still to share financial risk. So we're creating a new exception that basically says you can have remuneration to incentivize providers to participate in care coordination and use this exception in safe harbor, but it's going to be a much more restrictive and rigorous analysis, specifically from the perspective of the OIG and the anti-kickback statute. The OIG goes to great pains to say, if we don't have shared financial risk at issue, we don't really have anything to give us confidence that the incentive to overutilize has gone away. So we're not really willing to go very far in announcing this this exception. So the elements here, as you see, are common to the other exceptions and safe harbors at issue. But the next slide starts to get into a lot more specific detail that need to be met under both Stark and anti-kickback. So for instance, here, the only thing that you can protect from anti-kickback perspective is non-monetary remuneration. So money does not work, has to be in-kind items, services, products. Financial support is not protected. The party getting the remuneration in the arrangement needs to pay 15% of the cost of whatever it is that they're getting. The party that's providing the remuneration needs to be able to demonstrate what that cost is. All of the parties participating in the value-based arrangement under this exception need to do an annual report to the agencies each year, basically demonstrating how all their activities are actually achieving the supposed value-based outcomes that the agencies are trying to incentivize. And if it happens to be the case that you're not meeting those objectives, you have to terminate and unwind the relationship within 60 days. That's all for anti-kickback purposes. Stark is still a little bit more straightforward, but anti-kickback is much more restrictive under this exception. The other Stark law change I'll mention here, and this will be one example where CMS has given helpful clarification, has to do with indirect compensation. So indirect compensation has to do with a situation where you have a chain of financial relationships between a doctor and a referral source, for instance, like you have outlined on the slide here. And basically what CMS says is, first of all, they go back and they try to help people understand something that's been, I guess, a misnomer for a number of years, and that's that if you have an indirect compensation arrangement under the Stark law, the only exception you can use is the indirect compensation arrangement exception. That's been something that's confused people for a while. The other thing that they say, and there is one caveat to that, which has to do with a different category of Stark exceptions for what are called services. So group practices, academic medical centers, there's a different set of exceptions they could use. But if you're just talking about a compensation arrangement, and it's indirect, you have to use the indirect compensation exception. The other change that CMS tells folks here is that if you are in an indirect compensation world, they want you to be able to participate in these value-based arrangements. And what that means is that basically they're changing around the indirect compensation rules to say essentially that indirect arrangements will be able to take advantage of the same Stark law exceptions for value-based activities that I just mentioned. And as we continue on, patient engagement is kind of the next step.
Yes, so we have a new proposed safe harbor for patient engagement. It creates an exception to the definition of remuneration. It also serves for an exception for purposes of the civil monetary penalty law. So this basically protects arrangements for patient engagement tools and supports that improve quality, health outcomes, and efficiency. Here, the government talked about how the need for patient engagement is really critical to advancing care and reducing value, and so they're trying to create a new safe harbor that would protect certain arrangements like this. Of course, they're concerned about the backside and the flip side and improperly incentivizing patients to receive care. So they do impose a lot of limitations on this. So the most one to note right now is that it applies to tools furnished directly by value-based enterprise participants. So again, some of the limitations that Jesse just talked about. And it only applies to patients that are in a target patient population. And so there's some limitations and some challenges with this because you have to sort of identify this target patient population in advance. There needs to be like written criteria where you set forth what this population is going to be. Of course, this raises challenges for ACOs who have maybe beneficiaries assigned on the back end. You can't really assign and target patients in advance, so there's some challenges with that. The other challenge is the providing directly to the target patient population, so you can't receive funds and then funnel it through. It's also limited to in-kind tools and supports. There's no definition for what preventative items, goods, or services means. Here, OIG said that they wanted to create flexibility, and so they're not really going to define what they mean by that. They did give some examples, though. They talk about technology, so wearable devices would be something that they consider to be a patient engagement tool and support. Gift cards, cash equivalents are excluded, and there's also a limitation of $500 annually for retail value. there's perhaps the biggest limitation here is these engagement tools have to be limited to advance certain goals. And so here's the list on the slide. You'll see that they're all geared towards health improvement outcomes. And so you can't really give an engagement tool that doesn't advance health outcomes. The government did give some examples here. So we're like a smart pill bottle would count as something that they're thinking about here, where it dispenses medication on appropriate time so that individuals know when to take their medication. Other ideas would be parking vouchers, child care, those sorts of things that are going to allow individuals to receive services. Things that don't count are going to be like movie ticket vouchers, things that really are separate from patient care initiatives. Another big change here is we have a new proposed safe harbor for CMS-sponsored models. So just stepping back, I'm sure a lot of you know that the traditional model right now is that CMS will issue, the Innovation Center that issues protection for certain arrangements payment models. But these fraud and abuse waivers are really arrangement specific. So they only apply to certain arrangements and they only apply to those specific entities that participate in that arrangement. So you can't use it beyond that. What we're doing here is there's a new proposed safe harbor that would broaden that, and it would largely replace this model by model fraud and abuse waiver process. It wouldn't extend to commercial and private insurance arrangements that operate alongside but outside of the CMS-sponsored model, but it would allow individuals and entities to use a model that's been approved by CMS rather than going this individual method. The catch here is that CMS gets to decide who gets to use it and who doesn't. The idea is that they'll notify the industry if they're available. They can limit to specific types of providers, so it's not necessarily going to be available to everybody if they make it available. So there's going to be some limitations that CMS imposed for this one. We also have some changes to cybersecurity and the EHR exceptions and safe harbors. So for purposes of the anti-kickback statute, there's a new proposed safe harbor that addresses specifically the donation of cybersecurity, technology, and related services. The thing to know for this one is hardware is explicitly excluded, so it's not going to be protected here. But the thought is that the cybersecurity is such a big issue right now, and that the weakest link in a system can compromise the entire industry. And so there's going to be a new proposed safe harbor that would protect the donation of certain cybersecurity software and services. There's a list of conditions that need to be met for this donation, and there's a similar one that's being proposed with respect to the START law. So they're largely consistent. OIG and CMS coordinated a lot on these rules, and so there's not a whole lot of differences here. Again, hardware is excluded with purposes of START law. They're considering expanding this, though, to include the donation of hardware in certain limited circumstances. So if that's something that you all care about, it would be a good reason to submit a comment. The donation must be necessary and used predominantly to implement, maintain, and establish cybersecurity. And for purposes of this exception, there's no recipient contribution requirement. So we'll talk about, 15% contribution with respect to EHR donation. That's not required here. So it's really a broader exception than what we're going to be talking about in a couple slides. For purposes of START law, there does need to be written documentation for this. It needs to specify a couple, a list of different things, and the general description of the donation, the time frame. Although there's no recipient contribution requirement, it can be imposed on the entity that's donating it, so that doesn't mean that it's prohibited. So if there's a contribution requirement, that needs to be in the written agreement. What's interesting is we're going to talk a little bit about the EHR donation safe harbor. There's some overlap here, and so both OIG and CMS talked about the fact that it has been their intent all along that the donation of cybersecurity software would be included and could be used as part of this EHR donation safe harbors and exceptions. And the thought is that if you're donating an electronic health record system, you may want to also donate cybersecurity protection software that's going to protect that EHR. And so CMS and OIG both talked about the fact that it has always been the intent that cybersecurity would be included under those safe harbors and exceptions, but now we're just going to have a more express bucket for just cybersecurity separately. And the thing to know is that the cybersecurity rules are going to be a little bit broader and a little bit less challenging to meet. For purposes of the anti-kickback statute, there's going to be revisions proposed to the EHR donation safe harbor. It removes the sunset provision. So if you go back to 2013, back in 2008, they implemented this EHR donation safe harbor, and there was originally a sunset that was supposed to have the safe harbor expire in 2013. Right before that was set to expire, it was extended to 2021. This removes that altogether. The thought is that originally the idea was the EHR donation safe harbor wouldn't be needed long term because everybody would get up to speed with the industry. They would all have EHRs. You wouldn't need this any longer. The idea now is that they're recognizing that's not necessarily true. New technology is happening where it's improving. You may need to upgrade. You may need to replace your systems. There's going to be new entrants into the market that don't necessarily have an EHR off the bat. And so the thought is that this safe harbor is going to remain longer and it's not going to be sunset. For this one, there is a 15% cost sharing requirement, but they're proposing to potentially eliminate or reduce this for smaller rural practices. So that's something that may be worth commenting on if it's important to you. And again, as I mentioned, there is discussion in the rule about clarifying the application of cybersecurity technology. For purposes of STARK, it's almost entirely consistent with what OIG proposed with respect to the anti-kickback statute, remove the sunset provisions, they address interoperability in the deeming provision, implement some statutory definitions for information blocking, so there's just some technical things that are happening. It also retains the 50% cost sharing requirement, but again, talks about whether that should be reduced or eliminated in certain circumstances. And it also discusses the clarification with respect to the treatment of cybersecurity technology donation. Turn it back to Jesse.
And so we also have some changes to a few definitions that have always been very important for Stark Law compliance purposes, commercial reasonableness, fair market value, and what it means to take into account the volume or value of referrals. So these terms have been around forever. They've been around since 1998 when the proposed rule for Stark 2 came out. But over the years, particularly since 2010, we've had a lot of problems with these terms due to the way that key TAMs, so relators, so those are the people who file False Claims Act cases, U.S. Department of Justice, and certain court opinions have interpreted what it means to be, for referrals to be taken into account. And it's one of those classic bad facts make bad law situations where some of these court decisions have had the implication for healthcare providers of undermining or at least questioning very common arrangements in healthcare. So CMS has tried to take this opportunity to clarify what they mean about these three terms, and we'll talk about that now. One thing to be aware of is that these changes do not apply for purposes of the anti-kickback statute. So any of the anti-kickback safe harbors that talk about fair market value or volume or value of referrals, what I'm about to talk about now is not really relevant for anti-kickback analysis. Okay, so what do we mean by this? Well, I'm not going to go through this history, but prior to these new rules, it was necessary to go back and really consult all of this rulemaking from the Stark Law going back all the way to 1989. In that photo, that's Pete Stark back when the law was enacted. He looks very happy. When he retired, you can see him here. He looks equally happy, if not happier. It was really necessary to drill down and try to get to the bottom of what these terms mean. And commercially reasonable is probably the best example of that because, believe it or not, we never really had a definition of commercial reasonableness. You needed to go back to the proposed rule for 1998 to get a sense of what this was supposed to mean. The new regulations propose two different definitions of what it means to have commercial reasonableness in an arrangement, and you can see those two outlined on this slide here. The government is looking for comment about what these, what folks think as far as which arrangement or which definition makes the most sense. The first definition is really focused on the business purpose of the arrangement at issue, and the second is more about commercial purposes and what's happening with direct competitors. So it's a narrower definition that the government is thinking about using. A couple other clarifications they make here is to try to make folks understand that commercial reasonableness is different than fair market value. For a long time, people were starting to kind of conflate those standards. And they also make the helpful comment that you don't need to make a profit for something to be commercially reasonable. That's an example of one of the trends that was coming out of these court decisions, basically saying if there's no profit in a financial relationship, how could that be commercially reasonable? And that was creating a lot of questions for providers who need to have services that might not make money. So that's helpful clarification. And that would be an example of something that CMS says is their opinion currently, regardless of whether these regulations are finalized or not. That's their view of the world. So that's helpful clarification. The question of what it means for compensation to take into account referrals has always been extremely confusing and murky for folks. And the government, for Stark, is trying to take a totally new approach to what that means. And what they're basically trying to do is flip the analysis. Right now, the rules are set up in a way where the government defines the circumstances when compensation won't take into account the volume or value of referrals. And that's confusing for people because of the way that the definitions are written. So what CMS is proposing to do is basically flip that and instead define limited circumstances when compensation will take into account the volume or value of referrals. And if you're outside of that, then you don't really have to worry about it. And that's helpful clarification for folks as well. It is a little bit complicated. I won't lie to you, because they basically created 4 separate standards. And they told me when I went to law school that I didn't have to worry about math. But that's apparently changed, because now we have to think about whether we've got a positive correlation or a negative correlation in terms of doing this volume or value of referrals analysis. And I'll get into exactly what that means in just a second. A couple other sort of background points on this, though. CMS acknowledges that they've kind of been all over the place with what it means to take into account the volume or value of referrals. So what they say here is if they finalize these rules, these new rules will supersede anything that they said in the past that might be inconsistent with the new rules. That's helpful clarification. But then, of course, they also say, if we don't finalize these rules, you can't count on any of this. None of this matters. So kind of want to have it both ways. Okay, so what are the tests? Well, there's really, as I mentioned, there's basically 4 different ways to do it, and it kind of focuses both on the volume or value of referrals. So that's talking about designated health services referrals. So a doctor is ordering, hospital services or radiology services, any of the other things that are defined as designated health services. That's a referral. And then it also describes other business generated. And other business generated is basically anything outside of designated health services. And so essentially what we have now are 2 tests that are looking to whether you have a positive correlation or a negative correlation. And you apply that analysis both under the volume or value of referrals and the other business generated standards. And you also have to think about it in terms of the way compensation flows, because we typically think of Stark as where a hospital pays a physician for services, right? So you've got compensation going from the hospital to the doctor. But CMS says that's not the only analysis. The other question is the reverse of that, where compensation goes from the doctor to the hospital. Both of those situations can, implicate this volume or value standard, and that's why they have all of these multiple tests that they're proposing. So the next slide gives you the exact language for one of the 4 tests, which is about compensation from an entity to a physician and whether or not that takes into account the volume or value of referrals. And you can see here the first question is whether we've got this positive correlation between referrals and compensation. That's kind of one way to do the analysis, and the next slide will give you an example of what that looks like. And then the second way to do the analysis is if you have a predetermined correlation between prior referrals and compensation. And what they're trying to do with that second test is get at the situation where you've got fixed compensation, so $500,000 a year, no matter what happens. Could that ever take into account the volume or value of referrals? And a lot of people would say no, because it's a fixed amount. It's the same no matter what. So how could it take into account referrals? Well, what the government's trying to do with this second definition is say, yeah, but you need to look back. You need to look back before that, and you need to figure out whether there was anything going on at the organization that really was kind of like a back-of-the-napkin calculation based on prior activity that led to that compensation being $500,000. This is an area where they've unfortunately introduced more subjectivity because there's a quote in the regulations that talks about how merely hoping or even contemplating or anticipating future referrals is not going to be sufficient to show that compensation took into account the volume or value of referrals. But if you think about that, you can see how, well, that sounds nice, but what happens if you've got a bunch of emails going back and forth between business people at the organization talking about why we should pay the doctors this amount, they're going to generate all that work. That sounds a little bit different than what the quote, than how the quote works. So it's not a great test, in my view. In terms of how this actually shakes out, well, this will be an example of a volume or value of referral analysis. You've got a physician group with a professional services agreement with the hospital. Physicians refer to the hospital for services. So based on some of the False Claims Act cases I mentioned earlier, a very common payment model where you have physicians being paid based on their work RVUs for services in the hospitals. For a long time, people thought that would be just fine because the doctors are being paid on their personal productivity. And if you go back to early Stark Law rulemaking in that big series of slides they had about the history, you will see that CMS says it's fine to pay people based on their personal production, even if there is a facility charge or a technical component charge at the hospital or other DHS entity that relates to that professional service. The most frequent way this comes up is with physician services in a hospital setting. And based on some of these False Claims Act cases, judges and the Department of Justice started to say, no, that's not really right, because it looks to them like there's a correlation between a physician at the hospital providing a professional service and then the hospital getting to bill for something as a facility charge that results from that professional service. So in the opinion of DOJ and some of the key TAM relators and some of the court decisions, that looks like compensation took into account the volume or value of referrals. And that was very challenging for providers who have these work RVU-based payment arrangements. Well, the good news is under the new test, this model would be fine because there's no positive correlation between the physician services and the hospital and what happens at the hospital. Basically, the physicians are paid the same amount for their professional services regardless of what's going on with the facility charge at the hospital. The second option, though, would not work under the volume or value test under these new rules, because what's going on here is we've got a physician paid based on a percentage of collections for personally performed services, but also a percentage of collections from revenue at the DHS entity at the hospital that are generated by the physician but that are not performed by the physician. So in the eyes of CMS, we've got a positive correlation. The greater the number of referrals by the doctor, the larger that pool will be at the hospital, and the more the revenue will flow back to the physician under this model. The flip of this, looking at what happens when you've got a physician paying compensation to an entity, has the same two tests basically, but is instead of looking at a positive correlation is now looking at a negative correlation. So that basically means where one variable goes up, the other variable goes down, and you'll see what I mean in just a second as I give you an example. And then this similar test about predetermined compensation based on what happened in the past, whether that was set up in a way that anticipated referrals. So we look at an example. What happens if you've got a physician group that's leasing space from a hospital, $5,000 a month, but the parties set it up so that every time the doctors order a diagnostic test at the hospital, that lease rate goes down. Well, that would be a negative correlation because as the referrals go up, the compensation goes down, and that's what CMS is trying to prevent in that model. So the takeaway on this is that the guidance is a little bit complex. That's certainly the case, but it's helpful in the sense that it offers protection for these common payment models between physicians and hospitals, and I think will give comfort to folks participating in those arrangements that they don't have to worry about that as much, which is good news. The other thing, or another thing that's resulting from these regulations is a requirement that in the context of value-based arrangements, there's this incentive to try to keep patients within the family of entities. And the idea there is that if we're all working together in one of these value-based programs, we can essentially collaborate around treatment, and that will ultimately, accrue to the benefit of the patients through better care and to payers through cheaper care. So there should be the flexibility to, pressure or require or instruct doctors to refer to certain parties within the context of those arrangements. And this guidance has been around for a long time about requiring referrals under the Stark Law, but it's now taking on added importance. And basically what's happening here is that it's being imported into a number of the exceptions that are commonly used, so employment arrangements, indirect compensation arrangements, personal services arrangements will all have the requirement to comply with this if they're participating in value-based payment arrangements. Another important change has to do with the definition of fair market value under the Stark Law. CMS has done a couple of helpful things here. The first thing they've done is they made clear that volume or value of referrals is different than fair market value. Prior to this change, it was all kind of conflated together in the definition of fair market value, which was very confusing to people. So they made that clear. CMS has also pulled out office and equipment valuations from the definition of fair market value and created a separate standard for office and equipment valuations, and that's helpful as well because, again, it was all kind of mashed together, which was confusing for folks. The third thing they've done is they've taken the old definition of what is called general market value, which is a component of what it means to have fair market value, and they've really modernized it. CMS has basically taken general market value, which used to be defined based on old Medicare cost reporting rules. CMS recognizes that's not relevant to many folks anymore. And so what they're basically doing is they're taking general market value and they're standardizing with what the valuation community describes as market value. So moving away from hypothetical value in a hypothetical transaction and looking instead to the actual value between the actual parties in an actual transaction. So it's less of a hypothetical approach and it's more of an immediate approach. And what that means is that it's becoming less of a quantitative analysis and more of a qualitative analysis. And CMS gives some examples about an orthopedic surgeon who produces at $450,000 based on survey data not being at fair market value if you're paying him at that amount. If that physician is living in an expensive area, is the type of physician who has fame or unique expertise, someone who's hard to recruit, you can't find support or call coverage for this doctor. In a scenario like that, CMS is indicating that you need to take those factors into consideration because it may be the case that $450,000 is actually underpaying that physician. By the same token, they give the example of a family practice doctor where survey data says $250,000 would be appropriate for that physician's work, but $250,000 actually might be overpaying that physician in spite of his or her production if they're living in a low-cost area, what CMS describes as an area with a desirable lifestyle, or having good schools. And so, it'll be interesting to see how folks are supposed to demonstrate compliance with those requirements. But that is the scope of change for fair market value. And the other thing to remember about fair market value, commercial reasonableness, and volume or value of referrals is you don't have to worry about those standards if you're using these value-based exceptions under the Stark Law because they're not relevant anymore. So that is a helpful change as well. I won't talk about group practices other than to say that CMS has changed the rules to make it clear how group practices, so those are physician-owned groups, can participate in value-based arrangements. Another helpful change, though, has to do with what we call conscious uncoupling, which is a great term of Stark and anti-kickback. For many years, about 10 to 15 of the Stark exceptions have this kind of strange requirement that in spite of the Stark Law being a strict liability law, compliance also requires that you demonstrate you don't violate the anti-kickback statute and that you don't violate any law or regulation governing billing or claims submission, which could mean just about anything. And people have wondered for a very long time, how are you supposed to, when you're dealing with a strict liability law, comply with any of these exceptions if baked into that is complying with an intent-based law like the anti-kickback statute. So what CMS has done is basically gone through all of the exceptions and essentially just removed the anti-kickback and billing obligation as a requirement. In the last positive change that I'll mention here has to do with the government calls technical noncompliance, which is funny because it makes it sound like they think none of this other stuff is technical. But what they're saying here is that they back in 2000 and I think 13 it was, CMS for Stark law purposes said, if you don't get a signature on your contract, we'll give you up to 90 days to get the signature and you'll be okay. You won't violate the Stark law, even though the exception says you need to have a written agreement to meet the exception. And what they're doing now is they're expanding that, and they're basically saying not only do you not need the signature, you actually don't need the written agreement itself for up to 90 days as long as you meet the substantive requirements of the exception. So you can have a lease that doesn't have a written lease and still comply with the Stark law leasing exception as long as you're meeting the substance of the exception. And what they're trying to do is basically say, look, the self-referral disclosure protocol they have, which is where people can blow the whistle on themselves in a drastic penalty for a Stark law violation, has taught CMS that lots of people have problems with these very detailed sort of prescriptive requirements, and they're trying to give you a little bit more leeway for non-compliance. The one caveat I'll mention on this, though, is many of these exceptions still have a requirement that compensation needs to be set in advance. So that means you have to have some method of determining compensation before the arrangement starts to comply with the exception. You can't just figure out how payment's supposed to work after the fact. So you'll have to think about, if you don't have an arrangement in writing, you're trying to take advantage of this sort of leeway here, how are you also meeting the set in advance requirement, right? Because you can't, you need to have both in place. So that is one thing to keep in mind.
All right. CMS is also proposing some changes to the definition of designated health services. So specifically, the proposed change is that hospital inpatient services would not constitute DHS if the services do not affect payment under the Medicare IPPS. The idea here is that, let's say that you have an inpatient hospital admission, the patient is seen by the attending physician then refers this to a consulting specialist, and that specialist orders an x-ray. CMS talks about how the fact that at the time that there's this inpatient admission, this individual already has this composite rate set by Medicare. So the imaging that's going to be ordered by the specialist will be bundled into the payment rate. There's going to be no additional payment for this x-ray that's being ordered by the specialist. And in that case, although the x-ray would otherwise constitute DHS, it will not for purposes of that situation. And so there's going to be some clarifications proposed with respect to this specific situation here. It will not be extended, CMS says, to outpatient services because they think that the same arrangement won't apply in that situation. Comments are sought, though, on whether it should be expanded to include hospitals that are not paid on the IPPS basis, because that will, as it's written right now, only be applicable to those paid on the IPPS. There's some clarifications to the definition of physician. Really, this is just to reduce ambiguity. There's nothing major here. It's just there's an inconsistency in how it's being defined right now. And so they're proposing to remove this cross-reference just to make this definition a little bit more clear. Also proposing changes to the definition of referral. There's not a whole lot of commentary on this one, except for the fact that CMS is saying that it's seizing the opportunity to make this clarification on what it believes is to be a longstanding policy, simply saying that a referral cannot be an item or service for which payment may be made under the Stark law. There's some changes happening with respect to the definition of remuneration. And so the proposal right now, or the current rule, is that furnishing items, devices, or supplies is not included in the definition of remuneration. This does not apply to surgical items if those are used solely for the collection of transportation or to otherwise communicate the results. The proposal that's being suggested is that they're going to remove the specification about how it applies to surgical items, and the thought is that the rule should not be tied to the type of item, but rather whether it is used solely for those purposes. And so they're no longer going to look at what the type of item is. They're only going to look at the use solely test. there's some clarification on what the use solely test is. And the clarification is that it matters how it's actually used, not how it could be used. So there's talk about how a specimen collection box could be used to actually collect specimen, or it could be used as a doorstop. It matters how it's actually used in that situation, not the theoretical ways that it could be used. There's proposed changes to the definition of isolated transactions. The change here is that they're proposing to create a new freestanding definition of isolated financial transactions. So CMS has said that they've become aware through the self-referral disclosure protocol that some entities may be using the isolated transaction exception to protect arrangements where there's a single payment made for services that are provided over a period of time. And CMS is saying that that is not the intent of this exception. The intent really is supposed to be for only isolated financial transactions. And so there's clarifications by simply creating this new freestanding definition. They're not going to change the way that it's actually defined as the exception, but the thought is that that's been the intent all along. So there's going to be this new reference to freestanding isolated financial transactions. There's also discussion about the period of disallowance. So they're proposing to delete the rules on the period of disallowance. So this refers to the period of time in which a compensation arrangement does not comply with the START law. And when that's the case, a physician may not make referrals for DHS. The thought is that, again, through the self-referral disclosure protocol, CMS has discovered that these rules, surprisingly, are extremely complicated and individuals do not know how to follow them. And so they're proposing to just remove them entirely. They discovered that by having the period of disallowance rules, entities thought that they had to use this predetermined process to end the period of disallowance. That was not the intent. It's really supposed to be one option. And so the thought is that you can still continue to use this process, but it's not, quote unquote, mandated as the only way to end or cure a period of disallowance. The other interesting piece about this change is there's discussion about what it actually means to cure retroactively a period of disallowance. And so there's some discussion about if you have an arrangement, let's say you have a medical director arrangement where the hourly rate is supposed to be $150 an hour, but you're actually paying this medical director $145. And the thought is that that will not then meet the technical requirements of the exception. So technically there is a period of disallowance where you should not be making referrals for designated health services. In the past, entities have tried to fix that, and they've used the term we're kind of retroactively curing this by changing and doing the things that we need to do to bring it into compliance. CMS says that it does not consider that to actually be retroactive compliance. It's really just the active compliance program that entities are expected to have anyway. So if you're catching this while there's an ongoing compensation arrangement, then it's not really going to be an issue with respect to the period of disallowance. The issue arises when the relationship has ended, and that's when you have to then think about whether there is a period of disallowance that applies. There's general guidance on here. This is sort of what I just talked about, turning back the clock for a little bit more discussion on that. There's a new exception that creates for non-abusive business practices with respect to remuneration to a physician. Again, this is something that CMS has learned through its administration of the self-referral disclosure protocol. The example that they gave for this one is, let's say that there's an unexpected leave of a medical director and they need to quickly fill that position, but you can't do the things that you need to do to meet the other exceptions. This would provide for that limited situation where there's going to be remuneration to a physician. The interesting piece about this is technically this rule conflicts with a lot of other exceptions because there's rules that say, for example, you can't have same or similar arrangements within a calendar year. This could potentially violate that. There's rules under START that say you have to have a list on a master contract. CMS is acknowledging that this would conflict potentially with that, but they're kind of letting that slide and saying that some of those other requirements would not apply with respect to this new exception. Ownership and investment or investment interest. So historically, CMS introduced the concept of particular ownership or investment interest. The idea is that if a physician does not have the right to a distribution of profits or proceeds, There's really no incentive to refer for those purposes, and so it's not going to be considered to be an ownership or investment interest only with respect to the stand in the shoes discussion. And so historically, this rule had only applied when you're doing the stand in the shoes analysis as to whether a physician stands in the shoes of its physician organization. The proposal here is that this is going to be broadened to include not only the stand in the shoes situations, but also just broadly ownership or investment interests. There's discussion about the employee stock ownership programs, which would include the exclusion of those from the definition of ownership or investment interest as well. There's also being proposed an exception with respect to, or discussion about the rental or office space or equipment. So the idea here is that in the past, the rule has been that the leasee cannot, it needs to use the space exclusively. So there's a lot of discussion about what it means to use that space exclusively. The proposal here is that there's clarification that multiple lessees can use the same space as long as the leaseor is excluded. The whole intent of this rule is to prevent sham leasing arrangements, and CMS is acknowledging that there will not be a sham as long as the leaseor is still excluded from using the space, but there can be multiple lessees using it. There's also discussion around the fair market value exception, reconsidering its policy to make an exception available to protect arrangements for the rental of lease or office space. So this really, they previously had declined to make this exception available to these arrangements, and the proposal would be that this would change, that it would be available for the rental of office space, which would make it very helpful for short-term arrangements. There's modification that would broaden, being proposed, the definition of unrelated provision of designated health services. This gets a little bit technical. CMS had a really deep dive into the legislative history of this. And basically what they're introducing, the thing to know is that there's this new concept of patient care services, and that's going to be the defining factor as to whether it's related or unrelated to the provision of designated health services. CMS thinks that this introduction of this new concept is going to make it easier to make this determination. Payments to a physician, again, reconsidering position regarding the availability of the regulatory exceptions for this rule. So as it stands, you're not allowed to use this exception if there are other statutory or regulatory exceptions that are available. The proposal here is that if there are other regulatory exceptions available, you can still use this rule, but you cannot if there are other statutory exceptions available. So there's just kind of a tweak here that's really going to broaden the application of this rule. The last thing I'll say is about recruitment. So one of the key elements of the recruitment exception here is that there needs to be signed by the parties. And so the rulemaking throughout the years has clarified that as the rule stands right now, if there's recruitment by a hospital to a physician that ultimately ends up being engaged by a physician organization, technically all three entities need to sign that written agreement. The clarification being proposed here is that if this physician organization does not actually receive any remuneration, they do not need to be a party that needs to sign. There's some minor changes happening being proposed with respect to the non-physician practitioner rules here, simply just adding clarifications, really changing it from patient care services to NPP patient care services to clarify the role of NPPs. I'm going to turn it back to Jesse.
So we do have a couple more things to get to. We recognize we're at time. So if any of you have to go, don't worry. We won't be offended. That's no problem at all. And we'll probably just continue on and march through these last couple of things. Won't spend a lot of time on the themes behind these changes, the anti-kickback statute, safe harbors. But if you're wondering why they're more restrictive than Stark, the main reason for that is if you go back and look at the early commentary, OIG says the safe harbors are there to protect arrangements where there's, quote, no potential for abuse, so no potential at all. And that's the reason that the anti-kickback safe harbors tend to be quite a bit more rigorous than Stark. That being said, OIG has done a number of things to modify safe harbors in a way to not only make them work for value-based arrangements, but make them a little bit easier, generally speaking. And one of the areas they've done that is with the personal services and management contract safe harbor. So this is the safe harbor that's there to protect, a services agreement between a hospital and a physician group. It's historically been very challenging for providers to meet because it required that you specify the aggregate amount of compensation in advance of the arrangement. So not just the payment methodology, but the total amount of money that actually is paid under the contract. And that was really difficult to do. If it was based on production, for example, you wouldn't really know the answer to that question. And then the other thing it did is it required that any type of part-time arrangement needed to say exactly what the intervals of part-time services would be, so how many hours a day if it wasn't full-time, and exactly what the charge would be for that time period. And that was a challenge as well. So the safe harbor changed all that, did away with both of those requirements, and basically said that, like the Stark law, you just need to have the methodology for payment under the safe harbor, and that will work fine. You don't need to say the amount anymore, and you don't need to deal with part-time interval issue anymore either. And then, as this slide indicates, OIG has modified the safe harbor to try and protect payment arrangements that are outcomes-based. And so this is trying to help providers who have a contract for value-based participation have a safe harbor to use. This is a challenging one, and OIG acknowledges that because, for example, they have a fair market value requirement in this safe harbor. They basically say you have to show that compensation for services based on outcomes, based on patient results, based on reducing the cost of care, for example. You need to be able to define how compensation for the physicians in doing that work is consistent with fair market value, and they acknowledge in the commentary that it's really hard to do that currently, and they're asking for feedback from the industry about whether you should really have that requirement. And they also indicate that, that the volume or value of referral standard applies to the safe harbor, but it's not currently defined under the anti-kickback statute, and all of the guidance I talked about before under the Stark law isn't relevant to this analysis either. So OIG is saying, industry, tell us if that's a reasonable requirement to have. And then there are a number of other obligations as well, including that participants need to have clinical evidence and credible medical support to show what kinds of outcome measures are at issue in the arrangement that uses the safe harbor and how the services that the people are performing are actually working to achieve those outcome measures. So this is an area where we've got some helpful flexibility as far as scaling back the safe harbor as it's used currently, but the new approach to outcomes-based reimbursement, I think, presents challenges.
We're going to talk briefly about the warranty changes. So there's some revisions happening to the warranty safe harbor. As it stands, this safe harbor protects payments that are made in exchange for a warranty that's provided by a manufacturer for an item that's to a buyer. It only applies, though, for single items. The proposal is that this will expand to include also bundled warranties. The warranty, though, would have to cover still at least one item, so it can't be protection for service-only arrangements. There also needs to be, there's a list of requirements that the bundled arrangement would have to meet, and expressly excludes beneficiaries from the reporting requirements, but there's, again, no protection for the service-only arrangement. Local transportation. So the proposed changes here would just be primarily to expand the distance that's allowed to residents in rural areas. The proposal is that this will change from 50 miles to 75 miles. It also proposes to remove the distance to inpatients upon discharge. The thought is that transportation after discharge to home should be permitted without any distance limitation. They're seeking comments on whether this should be expanded to transportation to anywhere rather than just to a residence. The thought is that perhaps this individual needs to go to a different healthcare facility. Under this proposal, it would not be permitted. It also clarifies that ride-sharing arrangements are permissible. So they've commented, OIG has commented that this has always been their stance on this, that ride-sharing is just another example of local transportation, but this clarifies that. There's a few changes to civil monetary penalty for beneficiary inducement. So I want to know here there's a new proposed anti-kickback safe harbor. This really just implements a provision of the Bipartisan Budget Act of 2018, which carved out ACO beneficiary incentive programs from the definition of illegal remuneration. So the proposal is that it's going to codify this as an exception to the definition of remuneration. It doesn't really establish any additional requirements as what was in the Bipartisan Budget Act. It simply protects incentive payments made by an ACO to an assigned beneficiary who receives payment as part of this incentive program. There's another new exception for telehealth technologies for in-home dialysis. The Bipartisan Budget Act 2018 created this, it permitted certain end-stage renal disease patients to receive monthly clinical assessments via telehealth. So this would be a new exception that would permit the provision of certain technology in relationship to that. It really defines telehealth technology sort of broadly, and it's a fairly limited new exception, but it would really help those situations here. So we're just going to kind of come to a close. We realize we're over time. The final thoughts that we have primarily are, now is the time to make comments if you have them. There's a lot of content that Jesse and I didn't have a chance to cover. If you have any questions at all, feel free to reach out to us. Comments are due at the end of December, the 31st, I believe, by 5 p.m. Yep. So if you have anything to say, now's the time to say them. We'll expect, final rulemaking. It is on the docket for CMS and OIG. It's a really high initiative, so I would expect final rulemaking to actually happen. I don't know, Jesse, if you have any further thoughts you want to share.
Nope, I think that's it. Thanks so much for your attention, folks. We really appreciate you coming, and sorry for going long. We'll stick around if anyone has questions or wants to talk further. We appreciate it, though. Thank you.
Thank you.